Okay. Okay, hi, my name's Dr. Al Rundio, and I currently am Associate Dean for Nursing at Drexel University in Philadelphia, and I'm the immediate past president for the International Nurses Society on Addictions. And every year I do a CARN AP review. What is that? The CARN stands for Certified Addictions Registered Nurse, and the CARN AP stands for Certified Addictions Registered Nurse Advanced Practice, which are the two certification exams that are offered by the International Nurses Society of Addictions through CNET. So part of what I do is a full 8-hour day on prepping people on how to take the test, covering key topics. And of course, one of them is substances that are abused, how we assess patients. And of course, included in that, Milo, are the opiates. So we did this recording at the conference this past October in Charlotte, North Carolina, and what I've called out is a piece specifically addressing the opiates, and I'm going to talk about a couple other drugs too that, at least in my practice, I am seeing that quite frequently. If I didn't mention, I also am a nurse practitioner, and for the past 18 years I practice in a for-profit residential addictions treatment facility in southern New Jersey that I do primarily on weekends where I live. And we have right now 53 beds treating adults with a variety of substance use disorders. And I am on the inpatient side, so I treat people for the medical detox and for any primary care issues that the patient may have. We also do have 4 outpatient programs as well. So with that, let me get started. And what we're going to talk about are at least 2 major substances that are abused in U.S. society today. We will list 2 physiological effects of those major substances, and we will discuss at least 2 relapse prevention strategies, and they are my major learning objectives. And then I'm also going to focus specifically on opioid dependency, and we will also discuss treatment strategies as well as relapse prevention strategies for those clients who are addicted to opioids. Well, belief about addiction is that it's a biopsychosocial and spiritual disease model. It is a chronic disease. This I learned from my medical director several years ago, one that's never cured, but one that is managed and controlled. I remember when I look back at our facility, we had a guy by the name of Peter, who was an alcoholic who came in probably within a 6-month time span for his 4th admission. And I thought to myself, what are we really doing here? Each time he goes out, he relapses. And what I learned from Peter on the 4th time, something clicked in. And I really give this guy credit because he kept coming back because he wanted to maintain sobriety. Well, that was probably 12 or 13 years ago, and to my knowledge, Peter is still sober. So it is a chronic disease. My medical director taught me through people that we treat, like, for example, when we would send patients out to the ED, and maybe they needed some stabilization because we're a residential program. We don't do intravenous drugs. So maybe they needed, a banana bag in the ER for their alcoholism or for whatever substance they were abusing and some stabilization. But oftentimes, because they were addicted to something, the ER would reticently send them back. And my medical director would call the doctor and talk about it as a chronic illness. And he would state, if the diabetic came in with a blood sugar of 1,500, would you get the blood sugar down, sent them out, or would you send them right out? So there are certain illnesses in our society that are chronic nature that we accept, and then there are others that we don't accept. And of course, chemical dependency is one of them. So we're certainly change that attitude among our providers, and it has worked by providing education. I think it's also critical to understand that relapse prevention is a vital concept to understand, explore, and embrace. There are certainly many medications out there to help with people maintaining sobriety, and certainly through other types of therapy as well. And we'll discuss some of that. And I really believe that individuals do not elect to become addicted. We know that most of it starts in adolescence, because adolescents are experimenters. However, I really believe that no one wants to become addicted. There's something different about the person who has an addiction problem with their brain compared to someone who does not. So, although it's this biopsychosocial spiritual disease model, we know a lot about the biological component today through functional MRI and through positive emission tomography scanning that addiction certainly is a disease of the brain, and of course the other components fit in. Regarding spirituality, there's been research done, and we know that people who tend to engage either with some religion or engage spiritually have a much higher success rate of maintaining sobriety. So we really believe in these four components. However, what my medical director has taught me is that the brain biology is critical, and if we can hit different receptors with a variety of different medications that can help people maintain sobriety, that certainly is one of the goals in treatment. So let's then take a look at the brain. You can see the major areas of the brain to refresh your high school biology, and I am concentrating on the center of the slide where you see kind of like the orange band called the reward system. It really is the primitive hindbrain that drugs affect in the neuroreceptors, and it really is what we call the VTA, which is the ventral tegmental area. And I also want to point out the area above that where you see in purple judgment. So drugs will hit that VTA area, and then people will judge that or experience it as pleasurable. So the three major areas there, the entire area we call the ventral tegmental area, the VTA, includes the amygdala, the nucleus accumbens, and the prefrontal cortex. And you're seeing those areas noted in that picture in the brain. And then I've listed for you what they are. Again, we kind of call the overriding area the ventral tegmental area. Again, the major components are the nucleus accumbens, the amygdala, and the prefrontal cortex. Now, I want to talk about neuroplasticity. For many years, we thought that once neurons were damaged, you couldn't recover. You know, much like we think of cardiac cells, you know, the sarcomere, when it dies, it dies. But there's a new school of thought, and that's that the brain has the ability to basically rewire themselves. They can actually change structure and function in response to changes in the environment and through experience. So it has what we call the ability to change, which we term plasticity, and that can occur into older adulthood and through old age. And when we learn this through studying the human brain, it really is a phenomenal about it that neurons can actually regenerate and change themselves. Now, it's been demonstrated that the brain's physical structure and functional organization can really change. It can actually grow new neurons. And, you know, a lot of the scanning procedures that are available today have certainly assisted us in learning this, and that's functional magnetic resonance imaging and PET scanning, positive emission tomography. Those types of scans where we can really look at neurotransmitters and where we can really see into the deeper structures of the brain have really demonstrated what neuroplasticity is all about. And I can give you some examples. I always talk about, you know, Congresswoman Gabby Giffords when she was shot in the brain, you know, a few years back, shot in her head. And, you know, she's actually been learning how to redo things. It's amazing that she survived such an injury. I have a great example with my brother-in-law. He was in a very, very serious motorcycle accident. He was driving his motorcycle and a car went through a stop sign and hit him. This was back around 1980. And he had a helmet on. He had one of those suits to protect him, and the helmet actually split in half. And from the impact, actually, if you saw pictures of his face, it should be in a medical book, but his face, picture of someone's face facing you, is kind of split in half. He was brought into a community hospital, actually where I had worked, and when they turned him over, he stopped breathing. He was on his abdomen when they transported him by the rescue squad, and he stopped breathing, and it was really by the grace of God, as far as I'm concerned. The thoracic surgeon happened to be walking through the ER and said, "Do you need help with anything?" And he was able to intubate him, which saved his life. Because really, you have to picture the struggle that was before you, with his head kind of split in half, literally. He was in a coma for several months. He had burr holes. He had an ICP monitor, the whole bit. And he came out of it. Now, is he perfectly the same as he was, the day before the accident occurred in 1980? Absolutely not. But he's functional. He works. He drives a car. He definitely has traumatic brain injury. You can see it. He definitely, is probably not like you or I, but he's a functional member of society. And I know at the time I really had prepared my mother-in-law for his death, saying, I really don't think he's going to survive this. And he did. And so I didn't even know about neuroplasticity back then. I was a young nurse and didn't know him. And learning about it today, I always think of David, my brother-in-law, and what he went through. And you can look at it in people who have strokes and how they can regain brain function. And certainly with the elderly, by keeping people's brains active by doing like crossword puzzles. And there's several computerized programs out there where they don't progress as readily to dementia. So we do know that this is all possible today. And I guess the whole point in talking about it, related to an addictions lecture, is that, drugs do affect the brain and the neuroplasticity, but when you stop the drug, you can certainly recircuit those neurons. And that's what this is trying to show you, the transition to addiction, where you have this transient neuroplasticity, social use, and then you have periods of abstinence, and then you have relapse, and then you develop a stable neuroplasticity for whatever is going on, and that how that, can change, and how that also changes through neuroreceptors as well. This slide is showing you really that we know today there are just about neuroreceptors for every type of drug of abuse, and they will all function a little bit differently. And again, this comes from studying functional MRI and positive emission tomography. They've done in research centers where they've taken people who, say, have a cocaine addict and maybe have been drug-free for 3 or 4 years, and they'll put them into a PET scanner and show flashcards of, say, a chair, and there's no neurochemical release. And then maybe they'll flash a card of a table, and there's no neurochemical release. But then they flashcard a crack pipe, and there's a profound release of neurochemical, where the person actually craves the drug again. So definitely we know the receptors are involved, and there's something different about the person who abuses substances. There's something different in their receptor morphology, we believe. So when we look at addiction, we talk about the 5 C's, and that is continued use despite adverse consequences, chronic use, where you have to do it consistently, and then a loss of control. People develop a tolerance, and you can develop a tolerance for anything, and then you have this continued use, and you want to continue to use, and of course, when you reach a certain level, that amount doesn't satisfy anymore, so then you use more of the drug. You also become compulsive, and of course, if you don't have it, because usually of withdrawal symptoms, you then crave the drug. And these facts will change. You can probably look up some different facts every day, but addiction really affects at least 22 million Americans. We know the prescription opiate epidemic is rampant today. 75% of people who are addicted are in the workplace, and only 9% of Americans who need treatment actually receive it. So there's many more Americans that do need treatment, and that we know that there are new medications out to help control craving, and relapse is a normal part of the disease because it is a chronic illness. So a lot of our efforts today try to focus on relapse prevention, and we know that treatment can work. In fact, we've been very successful even when you compare it to other major substances. So the cycle of addiction, as I look at it, the cycle of addiction is that there is preoccupation and anticipation. And again, that would be like the adolescent through experimentation. That could come from peer pressure. They studied adolescents, and two of the leading factors that was done in one study was a lack of parental support where parents weren't around and low self-esteem. But there are many factors. You know, go back to your own adolescence. I know when I was coming out as an adolescent, you know, you would try to do things deliberately to aggravate your parents. You're trying to become your own person. So from doing history and physicals, because the center I'm at, once upon a time up until I guess it was about February of this year, we had a large adolescent population. And when I would do an H&P on an adolescent, they are experimenters, and they would try a variety of drugs, where an adult H&P, they would settle on one or two drugs. Okay? So definitely experimentation is in that adolescent phase. Then if they continue to use, they become intoxicated. And of course, the more they use, they'll build up their dependence and their tolerance, and they'll continue to use more. And then due to negative consequences, they may want to get off the drug, and then they'll go into withdrawal. And as you know, some drugs are more dangerous to withdraw from others, but they'll have physical symptoms. And this is where if we can get them into treatment and keep them comfortable, and then start to do therapy, you know, both counseling and individual counseling and 12-step meetings, and certainly medication management if needed, hopefully we can get them through that to where they'll want to gain sobriety. But if they don't get treatment, then they're probably going to start the whole cycle over again where they continue to use. So to talk about a few of the classes of drugs, I'm just going to mention a few and then really focus in on the opiates. But I want to talk about the depressants, and I want to say that alcohol is in here as well, and the anxiolytic class of drugs, because a lot of times when people, especially if they're withdrawing and they're seeing primary care, the primary care provider may not pick up that the person has a substance use disorder. So they present with things like anxiety, and then what they do, they, you know, medicate them. And oftentimes what they will prescribe will be an anxiolytic drug like Xanax or Ativan or one of those medications. And they are readily addicting. And I am seeing a lot more heroin addicts come in who are actually abusing the anxiolytic class of medication, be that prescription or off the street. Because a lot of times, even when it's prescribed, these people are exceeding the use, and you know they're abusing that drug as well, which can really be a very dangerous combination, especially when we look at the respiratory system. So, of course, these drugs cause euphoria and calmness. They decrease inhibitions. We will use them medically as tranquilizers and anticonvulsants, but they are easy to become addicted to, and they're difficult to withdraw from because of the long half-life. And of course, one of the dangers, as you know, both with alcohol, not considered an illicit substance, because we can buy that, you know, when we're of age in certainly depending on the state you live in a liquor store, or in some states in gas stations or even supermarkets. But also to withdraw from, it's very dangerous with this class of meds because of seizures. So in this class, certainly alcohol, your benzos, your barbiturates, things like rohypnol, gamma-hydroxybutyrate, the common names beer, wine, distilled spirits, Xanax, Valium, Rufus G, Liquid X. They can be ingested or snorted, and of course the effects are disorientation, poor coordination, slurred speech, headache, nausea, vomiting, diarrhea, and of course in some cases, if they take too much, unconsciousness. And with the opioid epidemic, especially the prescription opioid epidemic, we are seeing more complex clients today who come in and they're abusing, oxycodone or OxyContin or Vicodin or whatever they're using. And on top of that, they're also prescribed benzos and they're abusing benzos. And it can be a dangerous, dangerous combination when you combine the two. And of course, they're more difficult to manage because you want to control their symptoms, but you got to make certain you're not over-sedating them or depressing their respirations. This I found interesting. I found this hanging actually in our nurse's station, and I put it in there. And what this is just showing you the benzodiazepine dose equivalencies. And again, many times people will be taking these as prescription, but what are they equivalent to? So basically how we detox patients from the benzos or alcohol is through Librium or phenobarbital. Now, it's getting more and more difficult to get phenobarbital. There are some drugs in our country where they're not manufacturing them like they used to, and it's harder to get hold of them. And phenobarbital is one of them. So we have really switched all our protocols where I work to Librium. Plus the phenobar dose, basing where you were buying it from, was changing. Instead of like being, say, 30 milligrams or 60 milligrams, it was like 32.6 milligrams. And every time you tried to write a protocol or an order, you had to really look at the manufacturer and where it was coming from. So we tend to use Librium in these clients, but of course we have to go very cautiously if they're also abusing other drugs like heroin, again, because we have to be careful of the sedative effect. For seizures, especially with the benzos, our preferred medication is carbamazepine, which is Tegretol. We usually prescribe 200 milligrams BID, and then we do a serum level within 5 days. With alcoholics, you really have to watch liver function with carbamazepine, because sometimes I've seen it in a few patients where they'll build the level up too quickly. You'll quickly recognize that because the patients then become very mentally obtunded, disoriented, walking into walls, that type of thing. Or the other med we would use would be Depakote with the extended release tabs. And then, of course, we monitor those serum levels. Some of the relapse prevention, which can be used for alcohol and the benzos, and some of this will also be used for opiates, and I'll mention that in a minute. We'll go over these relapse meds, and we'll mention them again at the end of when I discuss opiates. But antabuse, which is disulfiram, very old drug, rarely used. I personally have not prescribed this. I think my medical directors maybe prescribed it twice. But that was a drug for alcohol, and it works on the enzyme system so that if you take alcohol by blocking certain enzymes, you will experience like a flushing and tachycardia. Now the danger is, depending how high the blood alcohol level is, if you're on antabuse, it can even cause many major symptoms, this antabuse alcohol reaction, up to and including death. So you don't see it prescribed much today, but you still may see it. More common, used for both alcohol and opiates, is Rivia is the brand name, or naltrexone. And in our alcoholics, again, you have to watch liver function. They have, if their enzymes are elevated too much in their liver, the oral version of naltrexone would not be considered. And naltrexone is also used for opiate because it blocks the opiate receptor sites. However, when you give it to someone who's coming off of opiates, they should be off opiates for, if you read the literature, it'll say 7 to 10 days. We usually use a 10-day window. And then back in 2006, a company came out with the idea of Vivitrol, which is an injectable naltrexone. So it's fine for your alcoholics if they have some impaired liver function because it's a once monthly IM injection. It must be given in the gluteus max, and you need a big muscle for it. You should use a Z-Track. It's a very viscous type of solution. But think about it. The naltrexone dose, normally we start at 25 milligrams if it's orally, once a day at bedtime for 3 days, and then build it to 50 milligrams once a day thereafter at bedtime. So if you have 50 milligrams for, say, 30 days, that's 1,500 milligrams of the drug. If you're taking injectable naltrexone, it's 380 milligrams as a once monthly injection. So you're using about like quarter to a third of the drug. And again, you're bypassing that liver because you're injecting it. And then the initial studies back in 2006 really centered on using it in alcoholics. However, it now has been opened up and is used also for opioid dependency. And again, these are relapse prevention drugs. And then the other drug for alcohol is Camprel, a camprosate calcium. This came out about in 1999. It's got a weird dose. It's a 666 milligram dose. The tablets come as 333 milligrams. So you take 2 of them to make 666, or to make 666 milligrams. That's 666, and you'll take that 3 times a day. It's felt to restore chemical balance in the brain of alcoholic patients, and in some patients it has been effective. So there are just a few of the relapse prevention drugs out there. We will mention naltrexone and Vivitrol again when we hit opioid dependency as well. And that's really the next class I want to talk about. I told you I was going to talk about primarily 2 classes. One was your benzo class, and now I do want to talk about the narcotics and the opiates. The opiates are derived from the opium poppy. Afghanistan is one of the countries that grows this extensively. We use them in hospitals and in outpatient centers for painkillers. It blocks pain. It produces euphoria. They are highly addictive, and they're found in snortable, smokable, and injectable forms. And ER visits have drastically increased the past few years. Now, the opioids, the drugs derived directly from the opium poppy are morphine and codeine. And then the semi-synthetic opioids, heroin is diacetylmorphine, hydromorphone is Dilaudid, oxycodone, Percocet, OxyContin, hydrocodone, Loracet, Vicodin, and then your synthetic opioids would be methadone, fentanyl, Darvocet, and Demerol. And then if dependence develops, of course, drug procurement often dominates the individual's life and often leads to criminal behavior. Now, how addicting are they? In some patients, they're going to be very addicting. I share a story, my grandson who I've raised, and he needed his wisdom teeth out. This is about 3 years ago. And his name's Gunnar, and his wisdom teeth had come down far enough that they didn't have to drill into the jawbone. So he actually had 4 wisdom teeth done under local by a very renowned oral surgeon in our area who everybody goes to. And I must admit he did an absolute phenomenal job. So I went with him, and I waited in the waiting room, and when we went in that morning, the nurse had asked for our pharmacy because they were going to call in a couple prescriptions for him. And so when he was finished and they called me back, and I got him. And they said they had called the prescriptions in to go to the drugstore and pick him up. And I said, well, I guess I'm going to have to pack his face in ice. Like give him ice packs. Because that's what I always remember, even when I used to work OR and in PACU, the recovery room, we would have to put ice onto people's faces with the, when they had their wisdom teeth out. So the nurse said, no, you won't have to do that. He should have no swelling because we did not have to drill into the jawbone. You only get that swelling when they drill into the jawbone, and his teeth were down far enough. So we left. He had to follow up, I think, a week later for a follow-up appointment. We went to the pharmacy and we picked up his prescriptions, and one, of course, was for an antibiotic, which I anticipated, and the other was for Vicodin, for 15 tablets of Vicodin. So my grandkid said to me, what are the scripts for? And I told them, and I said, you'll get the antibiotic, the Vicodin will stay with me, and if you really need that, you'll come to me, but I'm just not letting you have this. I said, we'll try Motrin first. If that doesn't work, then we'll think about the Vicodin. And that kid never used one Vicodin. In fact, I think the entire week you would never know that he even had his wisdom teeth out, because I think the surgeon is excellent. And he maybe used 2 or 3 doses of maybe 400 or 600 milligrams of Motrin, and that was it. And a week later, he was fully cured at follow-up, and he did great. So I thought to myself, now, why would they be prescribing him Vicodin? And I thought, well, he had his wisdom teeth out on a Thursday. If he had pain, maybe the surgeon doesn't want to be bothered on a Saturday. Maybe that's the reason. And then I often wondered in my head, could 15, and there was no refill on it, could 15 Vicodin addict someone? And then it was actually maybe about 6 months ago, I was doing an H&P on a 25-year-old who had come into our facility. And I always question them as to what gets them started on drug use. And he mentioned that he had had his wisdom teeth out, and it was a prescription for Vicodin that got him started and got him addicted. So I asked him how many Vicodin he had been prescribed, and it was 15 tablets. And then curiosity was killing me at this point, so I said, where do you live? And he lived in my geographic area, and I said, well, who took your wisdom teeth out? I won't say anything, it's confidential. And it was the same oral surgeon that my grandson had. So the point is, what went through my head is that, probably everybody who has their wisdom teeth out get this 15 tablets of Vicodin, probably unbeknownst to the surgeon, thinking, no one's getting addicted off of this. It's only 15 tabs. There's no refills. They're not coming back for more. They can't. And yet people are getting addicted to it. So with some people, it doesn't take much. Remember a counselor that we had where I worked who was a very hardcore heroin addict for years. She was 11, and she was living in Philadelphia at the time, the place where I work right now. And she, in a back alley, some guy asked her if she wanted to try something, and he shot her up with a bag of heroin. She said she passed out, and she was addicted from that time on. She said it was the best feeling she ever had. And for several years, she was a hardcore heroin addict until she went to a long-term treatment and then led a life of sobriety. So these drugs can be very, very addicting, and certainly with the opioid epidemic that we're experiencing today, I hate to say it, a lot of it has come from those of us who prescribe, and we really have to prescribe very cautiously. So what often happens when you do get the histories today, they'll start oftentimes with, well, they had back pain, or they were in a car accident, or they had surgery, and they start with an opiate, and then it progresses to where they're getting heroin. So heroin, diacetylmorphine, is more lipid-soluble than morphine, so it will cross your blood-brain barrier more easily. It causes a more intense euphoria and sedation. It gets quickly metabolized, will be excreted in the urine as free or conjugated morphine, and of course the effects are euphoria, sedation, and analgesia. And overdoses can cause respiratory depression, bradycardia, hypothermia, and death. Most individuals use it intravenously or nasal insufflation. You will find that there are some people addicted to it who absolutely hate needles, so they will continue to snort it. A lot of other individuals may start with nasal insufflation, but will progress to intravenous use. And then, of course, overdoses can result from the variability in the potency of the heroin, the rapid loss of tolerance after abstinence, and concurrent use of other central nervous system depressants and other physical complications. You know, in the Camden market across the river from Philadelphia, in the area that we call southern New Jersey, many of the heroin bags, you know, heroin will vary in potency by the geographic region. So in the Philadelphia, South Jersey market, it tends to be very potent, and many of the drug dealers are now lacing the heroin with fentanyl. And literally, people who have used like a bundle, 13 bags of heroin or more a day, take one bag of this stuff, and some of them are being found dead. That's how potent it is. In fact, we had a patient who came into treatment a few weeks ago, and admissions had to call 911 and Narcan him and get him out because he must have gotten hold of one of these bags, had taken it before he got to the facility, and he was just about breathing when he came in. So the potency can really be life-threatening. Withdrawal symptoms of opiates are going to depend on the type of opiate you're using. If you're using something that's longer acting, the withdrawal symptoms will start later. Something like heroin that's shorter acting, usually within 2 to 4 hours, you will start to see symptoms. And again, heroin has a short half-life, so those withdrawal symptoms tend to occur promptly and be more severe. The classic cadre of symptoms that you see when someone withdraws from the opiates are restlessness, lacrimation. You know, I say they lacrimate. They have runny eyes. They have a runny nose. The rhinorrhea, nausea, mydriasis, muscle aches, diarrhea. They'll have piloerection, which is goosebumps. And some patients may or may not be tachycardia and hypertensive. I really don't see that a lot with heroin addicts. Where you'll see the tachycardia and hypertension is if they speedball, where they do heroin and cocaine together, because then the cocaine effect is going to make them tachycardic and hypertensive. And that would be a sign, you know, you have someone who says they're using heroin, but they're really tachycardic and hypertensive. They probably have used a speedball where there's been cocaine involved. So how do we manage and detox these patients? Well, in our treatment center right now, we're using Subutex. I'll go into that in a minute. We use clonidine, which is catapreg. Even though most of us know it as an antihypertensive med, it actually works on the central nervous system. It can cause calmness. It can also affect the pain receptors, so people have less pain. You can use phenobarbital just to keep people a little sedate. We do not use that anymore. In our protocol, we have a little bit of Librium, like lower dose, around 25 milligrams Q6 for like 24, just to get them through a rough period until they get started on the Subutex. And then we use Subutex. Some centers use Suboxone. Subutex is buprenorphine, which is a Schedule III drug. The Subutex itself would be a partial opioid agonist, and the Suboxone has naloxone in it plus buprenorphine, so it's both a partial agonist and a partial antagonist. So the Narcan kind of like affects the receptors, but it's a very low dose of Narcan that is combined with the Suboxone, and it would maybe have more of an effect if someone used intravenously. If they're symptomatic and, for example, they have nausea or vomiting, you can use Compazine, you can use Tygan, you can use Zofran. It depends on your treatment center. Levsin is for abdominal cramping. It's a sublingual tab. We don't use that anymore. However, we do use Robaxin and Flexeril in our protocols. Robaxin is a muscle relaxant that generally does not make you sleepy, and Flexerol will make you a little bit sleepy. So we use Robaxin 3 times a day during the day, and then Flexerol at bedtime, and that's for the first 5 days. And generally, in our protocol, we start with lower dose Subutex, build up to around 8 milligrams. It's given as a film. Keep them there a day or two, and then start to wean them down, so that after about 5 days, they're off the detox protocol. Now, the beauty of Suboxone, the buprenorphine combined with the naloxone, so that's a great relapse prevention strategy, and many patients are appropriate to do long-term office-based outpatient therapy with buprenorphine, which usually is Suboxone, is what is used, and they can be given a month prescription by a qualified physician trained, and educated on the buprenorphine drugs, and it will be done outpatient. And it has a greater safety profile than methadone. And of course, I believe part of treating addiction is really counseling, individual, group, myelotherapy, alternative therapies if we can use, keeping people busy, exercise, getting them back to wellness. And of course, we believe in the 12-step philosophy in our facility as well. For relapse prevention, again, naltrexone would be one of the preferred drug. Again, also given as Vivitrol as an injection. The beauty of the Vivitrol, it's a once-monthly injection. You do not have to remember to take it. It is given by a treatment provider who is experienced with addictions. That's where the pharmaceutical firm will send the drug to. Again, you don't begin the naltrexone Rexall until at least 7 to 10 days that they're opioid naive. We use a 10-day window where you could cause acute withdrawal symptoms. Again, some patients will be appropriate for long-term Suboxone or Subutex therapy or methadone therapy in a methadone clinic. Suboxone, because of the naloxone component, is buprenorphine, which is a partial opioid receptor agonist, and an antagonist because of the naloxone, which is Narcan. The Drug Addiction Treatment Act, what we call DATA 2000, allowed qualified physicians to treat opioid-dependent patients with sublingual Suboxone in their practices. Initially, they could treat up to 30 patients at a time. A couple of years later, it was expanded to where they could treat up to 100 patients. This is an issue for us as advanced practice nurses or physician assistants because it's the one drug nationally that we're not allowed to prescribe for detox. And there is what's called the TREAT Act right now passing through Congress that would allow mid-level providers to prescribe this. Physicians have to complete a course that's now available online. Again, initially they could have a minimum of 30 patients, and then it was increased to 100 patients at a time. Certainly, if there was more than one physician in the practice, each physician could have up to 100 clients, so they could treat more patients. But with the huge opioid epidemic, I certainly think that nurse practitioners and physician assistants are key to helping physicians and could really help manage patients well if we were able to prescribe this. And then, of course, your drug enforcement agency monitors physicians prescribing Suboxone. I did put a caption there that right now we are not permitted to prescribe this for detox. Butrans is a buprenorphine transdermal patch for chronic pain, much like a fentanyl patch. Again, I think it probably would have a greater safety profile than fentanyl. Bunafal is another drug, and there are other drugs out there as well, which also combine buprenorphine and naloxone. Bunafal is very interesting because they have a unique delivery system. They have a proprietary bioerodible mucoadhesive, what we call BEMA delivery technology. So it's really on the buccal film that Bunafal works. So it basically, dose-wise, is double the bioavailability of a Suboxone film. Only half the buprenorphine dose is required. The lower dose may also reduce saliva buildup and side effects. So it was approved on June 6 of 2014 by the FDA. It was supposed to reach pharmacies by October of that year. And just to do a little dosing comparison, you can see that Bunavail, which would be buprenorphine 2.1 milligrams and naloxone 0.3 milligrams, is equivalent to a Suboxone film of 4 milligrams of buprenorphine and 1 milligram of naloxone, and so forth and so on. You can see Bunavail 4.2, 0.7, 4.2 milligrams is buprenorphine, 0.7 milligrams is naloxone, and that would be equal to Suboxone, an 8/2 milligrams sublingual film, 8 milligrams buprenorphine, 2 milligrams naloxone. So you can see that the Bunavail dosing is roughly half of Suboxone, but you're getting the same equivalency. I want to talk a little bit about methadone. Methadone is really a wonderful drug. I've seen it used for pain. It's great for really what I call hardcore addicts. I think people need to be screened appropriately. For example, we had a patient who had lived under the boardwalk in Atlantic City. I live in southern New Jersey for probably 20 years and was shooting like 3 to 4 bundles of heroin a day. Thankfully, because of course of IV drug use, especially if you share needles, you're exposed to hepatitis C, hepatitis B, HIV. She never caught any of those illnesses, but she did have endocarditis quite a bit. And when you would listen to her heart for assessment, she was a wonderful example of all the different types of murmurs that are out there. Well, no matter how hard we tried to detox her, and we tried 3 times, she would always relapse. And then we finally referred her to a methadone clinic. And this is over 10 years ago. I just saw her within the past few months. She's working 2 jobs, has an apartment. She had to have a couple valves replaced in her heart because of the damage to the heart valves from the endocarditis. But she basically has been heroin-free and took out all the other risk factors. Now, my medical director and I believe that her neuroreceptors have been so damaged over the years of drug abuse that she probably will never get off methadone, but at least she's a functioning member of society and she's not abusing drugs off the street. So it is administered orally. It's usually once daily dosing. The biggest, again, downfall to any of the opioids is the respiratory depression. So again, as long as the dosing is safe, the side effect profile is minimal, and it's safe and effective when dosed correctly. It's a long-acting full opioid receptor agonist. It functions at the mu receptor sites. The mu receptor sites exist on the surfaces of the brain cells, and the belief is that the activation of the mu receptors are responsible for the analgesic and euphoric effects of the opioids. The methadone kinetics, 80% gets bioabsorbed. The blood levels will peak within 2 to 4 hours, and you'll get pain relief in 4 to 6 hours, and the half-life, it's got a long half-life of about 24 to 36 hours. And that's what's dangerous about the drug usually is the induction phase, because the half-life is so long, it has a cumulative effect. So you can see you reach a steady state within about 5 to 7.5 days. Now, there are a lot of things that can affect the methadone kinetics. For example, the blood levels get influenced by absorption, metabolism, protein binding, urinary pH, other medications, diet, age, physical activity level, pregnancy, and vitamins. So the induction phase is really the most risky phase of methadone maintenance treatment. You want to start low and go slow. Kind of like I was taught to prescribe with the elderly. Always start low and go slow. And that's my philosophy in treating any person who's addicted. I'd rather start lower dose, other than the alcoholic who's like an acute DTs where you need higher dose, but generally starting low and building up as opposed to over-sedating them. So the treatment should be individualized. Optimal doses for patients will vary. You want to understand the cumulative property of methadone and communicate with your patients. So, this is using a clinical opiate withdrawal scale, the COW scale, And you can see when you assess them, if the score is 0 to 5, they're not in withdrawal. They don't get a dose of methadone. You can see even if they're in severe withdrawal with a score greater than 36, they're only getting up to 30 milligrams max of methadone to start because, again, you don't want to overdose them. You want to make sure that the doses are individualized. You want to titrate the dose to achieve a steady state with methadone levels. Really allow time to react to the initial dose. Allow time to react to a dose increase, generally 3 to 5 days. In other words, the patients may come back complaining each day they're not medicated enough. Keep them at the same dose because you're going to double the dose through the cumulative effect just by giving them the same dose. So what some clinicians will do, they'll want to keep upping the dose, and by the 7th day you could have a terrible cumulative effect that now the patient stops breathing. So you want to go low and slow and maintain the steady state and really be tuned to assessment. If I give them a dose of 30 milligrams and the next day they're euphoric and still no pain and everything's wonderful, I maybe gave them too big of a dose. Maybe we need to cut the dose back. So I want to show you an example of the cumulative effect. If dose A is 30 milligrams daily with no increase for 6 days, so for 6 days they're getting the same dose of 30 milligrams, the cumulative effect by day 6 is almost equal to 60 milligrams of methadone. It's doubled the dose. Okay? Look at dose B. Initial dose of 30 milligrams on day 1, then the dose gets increased daily by 10 milligrams for another 5 days. So on day 2, the dose is 40 milligrams. Day 3, it's 50 milligrams. Day 4, it's 60 milligrams. Day 5, it's 70 milligrams. Day 6, it's 80 milligrams. By day 6, that cumulative effect of dosing is 140 milligrams, close to 140 milligrams. There was a case, I taught this with a psychiatrist, a colleague of mine, and he actually was on a case where that dose B schedule was given. And it was a woman who had a sketchy history of opioid use to begin with, but around day 2 or 3 she's complaining to one of the nurses that she's not feeling right. She thinks maybe she's too oversedated, and the response was, you're on this protocol. This dose B was a protocol. You're on this protocol. Just take your medication as prescribed. And at the end of the week, her sister called her and didn't get an answer, so she went over to her house, and she had died from a methadone overdose. From the cumulative effect, she was sitting in her living room chair dead. So the cumulative effect can be great, and that's why it's really meant not to increase the dose that much. Really go slow if you're using methadone. So any sign or symptom of overmedication during the early induction phase requires a dose reduction. Be aware of those subtle signs and symptoms of overmedication, like feeling too good, extra energy, staying awake, they're not feeling anything. Patients oftentimes just need more time. Some of the adverse reactions are what we typically see with the opiates, things like constipation, excessive sweating, paresthesias in the hands and feet, weight gain, certainly decreased libido, and some people develop a rash. Conditions that can affect the dose are listed here: age, hepatitis C, HIV/AIDS, cardiac, pain, pregnancy, lactation. In pregnancy, when mom's in the 3rd trimester, that fetus is going to be taking more methadone. Those people are going to start with withdrawal. They're not med-seeking. And any pregnant women who's on methadone should be maintained on methadone throughout the pregnancy, because you can have fetal demise if you abruptly stopped it. And there is an FDA black box warning. Methadone can cause a prolonged QT syndrome in doses greater than 200 milligrams or with IV administration. And of course, the danger of a prolonged QT is torsade de pointes, which is kind of like an intermittent fib and ventricular tachycardia. So one of the big questions is, should we be doing an EKG pre-administration? Some centers don't, some do. Some will do it when the dose reaches 100 milligrams, like when they're at the halfway mark. But you got to keep this in mind. And this is torsades. This is a picture of torsades. And what you can see is kind of like, if you're familiar with EKGs, the smaller segments, the smaller height segments being almost like V-fib, and then your larger segments like ventricular tachycardia. Most people, when they go into this rhythm, are clinically dead and need to be shocked and need to figure out what's causing it. In this case, it could be the methadone. There are also other drug interactions. Certainly, anytime people are on opiates, the sedatives, antidepressants, some of your HIV meds, some antibiotics, antifungals, especially the drugs that will either induce or inhibit the CYP450 enzyme system. So there's no relapse prevention medication that can be effective without counseling and psychotherapy. And we discussed some of the relapse prevention medications in this lecture today. The issues and triggers in a patient's life that contribute to dependence and addiction have to be explored and addressed. We have to get into people's heads to figure out what's going on and how we can help them. So all the relapse meds will tell you they don't work by themselves. You have to have ongoing counseling and psychotherapy. If you believe in the 12-step process, the 12-step meetings. And I listed some websites for you. Certainly NIH.gov has some excellent information, your National Institutes of Health. Certainly CSAT, your Centers for Substance Abuse Treatment, an arm of the Substance Abuse and Mental Health Services Administration, also has tip documents and wonderful documents on opioids and the treatment and relapse prevention. So it's really been my pleasure to present to you today. Again, I'm re-recording this from what we did at our conference, so I don't anticipate any questions today, but hopefully you'll learn from this and you do further exploration as we all try to combat the opioid epidemic in the United States. And this slide says, I love this slide, it's not an easy job. So the toothbrush is saying sometimes they feel that I have the worst job in the world, and of course the toilet paper says, yeah, right. And with that, here is my contact information. I've listed my cell phone, which is an excellent way to get me. You have my work phone there and my 2 email addresses. So with that, I will draw this webinar to a close. It's been great to present.